This is the last recording for chapter 28. So, talking about preparation for transport for supine patients, we truly are probably just going to go ahead and secure them to a long backboard. More often than not, there is the availability of the vacuum mattress, but a lot of times that's going to be utilized for more longer transports than anything else. Um, when putting the person on the backboard, you're going to try and use a four-person log roll. Realistically, we don't always have four people, so you get relatively good at doing just a two-person log roll if you need to. Um, so we've practiced that, and we'll continue to practice that during lab days. Sometimes you just have to get creative, so make sure that you need to be flexible. For a vacuum mattress, it's kind of an alternative to the long backboard. It molds to the specific contours of the patient's body, so it reduces pressure points, which therefore long-term provides comfort. There are vacuum splints. This is basically a body sized vacuum splint. It also provides for thermal insulation. Our patients tend to get pretty chilly being on the backboard because it's typically made out of hard plastic, so it pulls a lot of body heat away. This doesn't. Vacuum mattresses tend to work a little bit better for people that have major curvatures of the spine, more so than normal. However, there are some drawbacks here. It can't be used for a patient who weighs more than 350 pounds. It also is pretty darn thick overall, so it's kind of cumbersome to move around, but it can be used on a patient that's supine, sitting, or standing. And then you can end up moving that vacuum mattress either with a scoop stretcher or you can put them on a long backboard after you do that if you need to. For seated patients, you can use a short backboard, which is basically like the long backboard that we use, except cut in half. Or you can use the KED device in order to help facilitate moving the patient out. You are then going to secure that short board to the long backboard. Not super comfortable, but it works. When we end up not securing a patient to either a short board or to a KED is when you or the patient is in imminent danger. You need immediate access to other patients, and then their injuries, they need out now. You may have to use some more rapid extrication type techniques. And we did go over some of those, and we'll continue to cover those in lab as well. For standing patients, it's best to immobilize the patient to a long backboard prior to actually getting through your assessment. You have 3 EMTs that are required for the absolute best way to do this. So you'll have one that establishes inline stabilization of the head, and then you apply the cervical collar. You're going to position the board upright directly behind the patient. You'll end up standing one EMT on either side of it, and you actually grasp your inside arm up under the patient, up under their armpit, grab the board with the other one. The third person is simply for being in the back to stabilize the patient's C-spine. And then you're going to step forward and lower the patient down. This is something that's much better demonstrated by video. So I will post a video of a standing takedown for you. You can do it with 2 people, but it's not as secure. So I'll go ahead and post that for you guys because I know that description made absolutely no sense. For spinal immobilization devices, we just want to assume that we're going to put any sort of person in a spinal immobilization device, be it longboard, shortboard, KED board, for anybody who has sustained a head injury. We're just going to suspect that a spinal injury is there. And we don't ever want to take a huge risk on that because any manipulation of an unstable C-spine can cause permanent damage. Oftentimes, patients will still have motion within their neck. They won't even know that they have a spinal injury because a lot of times they're relatively stable, broken but stable, but any extra manipulation of that break can cause it to become displaced and or unstable. We have a couple of different options. We've got the long backboard, but then we also have our short backboard or our KED. They are different. This that you're seeing is the KED. What we use in lab day is the KED, but there are legitimate short backboards that just look like a cut off longboard. Here's our typical longboard. This is actually a older version because it's made out of wood, which you can't CT through. So all of our new ones are pretty much made out of plastic that is able to go into those imaging devices. They're a lot lighter overall. We had some of these wooden backboards in the military, and they were heavy, extremely heavy. They do make a lighter version, but we don't get the fanciest stuff. And then you've got the buckle straps on here. There's a couple of other ways to do this. You've got the head blocks that are actually secured to the board rather than taping them on. Pluses and minuses with all of them. So, but typically same way to use them all. For helmet removal, a helmet that really fits well on the patient and doesn't compromise an airway, just leave it. There's no reason to remove it. Like football helmets, you've seen where they just cut the cage off, the face protector off. That's so much better of an option, especially if they have pads on, because those pads lift the head further up than it should be. If you take that helmet off, they're not going to be in a neutral inline position anymore. Oftentimes riding gear for somebody that has a motorcycle, if they're wearing the jacket, the vest, all of that, it's got extra padding behind the shoulders as well. And so if you take their helmet off, now they've got more of a void and the head is going to move out of that neutral position. If they are having a problem with airway or breathing, if it interferes with your assessment or your ability to actually ventilate the patient, or you cannot properly immobilize the spine, then you can go ahead and remove that helmet. If the helmet itself is full-faced, you're definitely going to want to remove it. If you can't flip up a visor or something, certainly go ahead and remove it because you want to make sure that you have the ability to protect the airway. If it allows for excessive head movement, one of the biggest problems is that people say, well, I'm wearing a helmet. Well, the thing is with helmets, they're supposed to fit extremely tight so that there's no chance for your head to bounce around in there. That's probably one of my biggest pet peeves is little kids that have helmets on and the chin strap is so loose that the helmet is actually not even seated on the head properly. It's tipped all the way back and you can see their poor little foreheads. Well, they have a helmet on, but it's not really protecting them. It's more of just a weight on the top of their head than anything else. They're very cognizant of this in football as to how close that has to fit. So that tends not to be a huge issue, but it's more public, non-organized arenas in which you're going to have problems with helmets. And then if the patient's in cardiac arrest, go ahead and remove it. Preferred method of removing, there should be at least 2 people that are helping to remove it. You have 2 hands that are controlling the head of the patient and 2 hands that are actually removing the helmet. It depends on the type of helmet that you have, and the 2 of you should be very systematic in how you end up removing the helmet. You want to make sure that you first consult with medical control about your decision to remove the helmet unless there's a clear-cut reason why you're removing it. If the airway is compromised, we're not going to stop and make a call to our med director, but we do need to let them know that we decided to pull that off. An alternate method allows the helmet to be removed with less force, so you're not going to be moving the neck around a whole lot. The disadvantage is that it takes a lot more time. So you end up removing the face or chin strap, the face mask. You're going to take the jaw pads and pop them out of place and get your fingers way up in the helmet. And then the person that's at the side of the patient's head controls the jaw with one hand and then the occiput of the other. So they kind of curve around the back of the head. You want to insert some padding behind the head itself so that once the helmet comes off, the head doesn't drop down. And then the person that's at the side is responsible for making sure the head and neck don't move. Keep in mind that if you've got a small child, they may need extra padding in order to maintain that inline neutral position. And I will make sure that on our next lab day, we've got a helmet here so that we can work through how to remove it. And I'm not talking so much about like the little bicycle helmets that you just need to be a little more weary of. The ones that are hard is like the motorcycle helmets with the full face piece. That's more helmets that get tricky. Other than that, that is the end of chapter 28 recordings.